Bismillahirrahmanirrahim. Today's lecture is about pulmonary embolism. By the end of this lecture, you will be able to define pulmonary embolism, identify the causes and the risk factors, understand the pathophysiology, know the symptoms and signs of a patient suffering from pulmonary embolism, identify the investigations and the different methods of treatment of pulmonary embolism. Pulmonary embolism, or in another word, pulmonary venous thromboembolism, is a common, serious, and potentially fatal complication of thrombus formation within the deep venous circulation. It is the third leading cause of death among hospitalized patients. Pulmonary emboli develop in 50 to 60% of patients with proximal DVT, and by the end, pulmonary embolism and DVT are two manifestations of the same disease with common symptoms and signs, almost the same investigations and methods of treatment. The causes of pulmonary embolism and thrombosis within the deep venous system is the most common cause of pulmonary embolism, or what we call DVT, keeping in mind that DVT is the most common cause of pulmonary embolism. Other causes of pulmonary embolism include air embolism, which rarely occur during neurosurgery or from central venous catheters. Amniotic fluid embolism is another cause which occurs during active labor by passage of the amniotic fluid to the deep venous system, fat embolism during long bone fractures, and others which are quite rare are foreign bodies, parasite eggs, septic emboli, and tumor cells. We will discuss a case scenario and we will pass through the symptoms and signs, the investigations and treatment through this case scenario. And 32 years female patient, pregnant, computer science engineer and heavy smoker, complaining of shortness of breath of 2 days duration. Her condition started on presentation to the emergency department, complaining of dyspnea of 2 days duration associated with palpitations, cough and expectoration of blood-tinged sputum, stitching, chest pain, and recurrent syncopal attacks. So we have a patient presenting to the emergency department complaining of dyspnea, palpitations, cough and expectoration of blood-tinged sputum, stitching, chest pain, and recurrent syncopal attacks. This was associated with swelling and redness of the left calf muscle after long air flight. On examination, she was tachycardic with a heart rate of 130 beats per minute. She was also hypotensive. Her blood pressure was 80/50. Chest examination was clear. On cardiac auscultation, she had an accentuated second heart sound and tender swollen calf muscles. Her past history, she gave a past history of recurrent abortions, and the family history was relevant. Starting with the risk factors of both DVT and pulmonary embolism is what we call Virchow's triad. The Virchow's triad is a triad of venous stasis, injury to the vessel wall, and hypercoagulability. Those are the risk factors for both DVT and pulmonary embolism, or what we call Virchow's triad. The hypercoagulability are further classified into acquired and inherited risk factors for hypercoagulability. The acquired risk factors are prolonged immobilization, trauma, surgery, obesity, and smoking, pregnancy, use of oral contraceptive pills and hormonal replacement therapy, malignancy, myeloproliferative disorders, and antiphospholipid antibody syndrome, heparin-induced thrombocytopenia, nephrotic syndrome, and inflammatory bowel disease. The inherited risk factors for hypercoagulability are deficiency of the natural anticoagulants, which are protein C, S, and antithrombin 3, the factor V Leiden and prothrombin gene mutation, and elevated factor 8 levels. Based on the risk factors, both the acquired and inherited, which we previously stated, and back to our case scenario, our patient was pregnant, which is one of the risk factors. She is a computer science engineer, so she stays on her office for long periods. This is another risk factor, which is a prolonged immobilization, and she is a heavy smoker. Also, we stated that smoking is an risk factor. She started complaining of swelling and redness of the left calf muscle after a long air flight. Long air flight also is an risk factor due to prolonged immobilization, especially in long air flights. Like going to US and Canada. So we have several acquired risk factors. Also, she gave a past history of recurrent abortions, which should alarm us for one of the inherited risk factors, which is antiphospholipid antibody syndrome. The patients who have antiphospholipid antibody syndrome usually give a history of recurrent abortions. Regarding the pathophysiology of pulmonary embolism, what happens at the level of the pulmonary circulation in the presence of thrombus? In the presence of thrombus occluding one of the pulmonary arteries, the pulmonary vascular resistance increase markedly, resulting in a pressure overload on the right ventricle. This leads to two pathways. The first is an increased RV wall tension. The increase in RV wall tension increase our oxygen demand, which results in RV ischemia or infarction. And this is associated with an decreased RV oxygen supply due to the decreased coronary perfusion due to the increased RV wall tension, resulting in an decrease in systemic arterial pressure. On the other side, the RV pressure overload causes an RV dysfunction. This results in two pathologies and decrease in the RV cardiac output and pushing the interventricular septum to the left side, compressing the LV. Both leads to a decreased LV preload, decreasing the LV cardiac output. Again, the pulmonary embolism, closure of one of the pulmonary arteries, increase the pulmonary vascular resistance, increasing the resistance of the blood going to the pulmonary arteries. This results in a pressure overload on the right ventricle. This causes two pathologies. The first is RV dysfunction. The RV dysfunction, RV contractility decreased markedly, resulting in decrease in the RV cardiac output, decreasing the blood supply going to the lung, and on the other side it pushes the interventricular septum toward the left ventricle, decreasing the capacity of the LV to accommodate blood, or decreasing the LV preload, decreasing the LV cardiac output. On the other side, the RV pressure overload increases the tension on the RV wall. This increases the myocardial demand for oxygen, resulting in RV ischemia, and the RV wall tension also causes a decreased coronary perfusion due to compression on the coronary arteries, resulting in also RV ischemia and due to the decreased RV oxygen supply. Again, the increase in the RV load results in RV dilatation, a tricuspid valve insufficiency, increasing the RV wall tension. This results in a neurohormonal activation, myocardial inflammation, and increased RV oxygen demand, resulting in RV ischemia and hypoxic injury, decreasing RV contractility. The RV output to the pulmonary circulation, decreasing the LV filling, decreasing the cardiac output, and the systemic blood pressure. And as you see, this is a vicious circle. Going to the symptoms and signs, the most common presenting symptoms of pulmonary embolism are dyspnea, which could be either at rest or with exertion, and pleuritic chest pain, which is usually described as stitching chest pain, cough, and expectoration of blood-tinged sputum. Orthopnea is quite rare, and usually the patients with pulmonary embolism have an associated DVT, as we mentioned that DVT is the most common cause of pulmonary embolism, so usually the patients have an calf or thigh pain or swelling or both. The patients with pulmonary embolism might have an chest wheezes due to bronchospasm and hemoptysis. What are the most common signs? The most common signs are tachypnea, increased respiratory rate, as we mentioned, calf or thigh swelling, erythema, tenderness, and palpable chords due to DVT, tachycardia, decreased breath sounds, which is quite rare, and accentuated second component of pulmonary component of the second heart sound. This is due to pulmonary hypertension, due to obstruction of a part of the pulmonary circulation, and jugular venous distension. Back to our case, the patients had dyspnea, which is the most common symptom. She had palpitations, she had cough and expectoration of blood-tinged sputum, and stitching or pleuritic chest pain, and recurrent syncopal attacks due to decreased cardiac output. She had swelling and redness of the left calf muscle due to the DVT, which is the most common cause of pulmonary embolism. Regarding the signs, she was tachycardic, she was hypotensive, her respiratory rate was 40 beats per minute, and she had an accentuated second heart sound due to pulmonary hypertension and tender swollen calf muscles. Going to the clinical probability risk scores. What is the clinical probability risk scores? We have scores for the patients presenting with symptoms suspicious of pulmonary embolism. If you have a patient presenting with symptoms suspicious of pulmonary embolism, you have an risk scoring system to determine whether this patient is an high risk for pulmonary embolism, intermediate risk of pulmonary embolism, or low risk for pulmonary embolism. Or sometimes they are classified into pulmonary embolism is unlikely in this patient, or pulmonary embolism is likely in this patient. We have two scores, the Wells score and the revised Jennifer score. Both scores are used simultaneously, and you have to memorize the scores. Starting with the Wells score depend on 7 factors for determining the probability for having pulmonary embolism. The first is if the patient have a previous history of DVT or pulmonary embolism. If the patient is presenting with tachycardia with a heart rate of more than 100 beats per minute, if the patient had a history of surgery or prolonged immobilization within the past 4 weeks, presence of hemoptysis, presence of active cancer, if the patient have an clinical signs of DVT, and the last thing is alternative diagnosis less likely than the pulmonary embolism. What is the meaning of alternative diagnosis less likely than the pulmonary embolism? It means that you are convinced that the patient's symptoms and signs are going with having a pulmonary embolism, and according to this parameter, the patient is given a score, and according to this score, we may say that this patient has a low risk of pulmonary embolism, an intermediate risk of pulmonary embolism, or high risk of pulmonary embolism, or we can say that the pulmonary embolism is unlikely in this patient if the patient score is from 0 to 4, or pulmonary embolism is likely if the patient score is more than or equal 5. The second scoring system is the revised Geneva score. The revised Geneva score is quite complicated than the Wells score. It depends on several factors, starting with the risk factors. If the patient age is more than 65 years, this is one of the risk factors. Having a previous DVT or pulmonary embolism and surgery or fracture within 1 month, and presence of active malignancy. If the patient have unilateral lower limb pain suggestive of a DVT or hemoptysis regarding the clinical signs, if the patient's heart rate is from 75 to 94 beats per minute, this gives the patient on the scoring system 3 points. If the heart rate is more than 95 beats per minute, this gives the patient 5 points on the risk score. If the patient has pain on the lower limb suggestive of deep venous thrombosis and unilateral edema, this gives the patient 4 points. And according to the points calculated to every patient, we get a probability. If it is from 0 to 3, then this patient has a low probability of pulmonary embolism. If it is from 4 to 10, then this patient has an intermediate probability of pulmonary embolism, and if it's more than or equal 11, then this patient has a high probability of pulmonary. So, after diagnosing a patient with pulmonary embolism, what should we do for this patient to make sure of the diagnosis? The investigations are classified into firstly laboratory investigations. We can do the patient an arterial blood gas. The arterial blood gas will show an severe hypoxia and respiratory alkalosis, keeping in mind that this is not diagnostic. You cannot depend only on the EPG to diagnose a patient with pulmonary embolism. The second is the D-dimer level. The D-dimer is a degradation product of cross-linked fibrin. It is elevated in level of thrombus, and it is a good negative test. It's non-specific, so it has a false positive results. It may be elevated in the presence of infection, in the presence of malignancy, in the presence of fractures. However, it is a good negative test if we are suspecting that this patient have a pulmonary embolism, and we did the D-dimer and the D-dimer is negative, so we can exclude that this patient has a pulmonary embolism. Troponin and brain natriuretic peptides are mainly for prognosis rather than diagnosis. We usually do these tests to know the prognosis of the patient. What will we see in the ECG in patients with a pulmonary embolism? As we mentioned in the symptoms and signs, that those patients have palpitation due to sinus tachycardia, so we might see sinus tachycardia in the ECG. We also might see an AF. Patients with pulmonary embolism might present with atrial fibrillation. And if you could remember from the ECG lecture that we mentioned that one of the causes of P pulmonale, to remind you, is an elongated P wave in the ECG. One of the causes of P pulmonale is pulmonary embolism, and as we mentioned in the pathophysiology, that pulmonary embolism causes an RV load tension on the RV, which results in right ventricular hypertrophy. Right ventricular hypertrophy is demonstrated in the ECG as tall R in the anteroseptal leads, tall R in V1, V2, and V3 with T wave inversion. Going to the imaging investigations, what we can see in the chest X-ray in patients with pulmonary embolism, Chest X-ray is mainly used to exclude the other lung diseases which might explain the dyspnea in patients with pulmonary embolism. There are specific signs in the chest X-ray conclusive of pulmonary embolism. These signs are the watermark sign and the Hampton sign. What are the watermark and Hampton hump sign? The watermark sign is, as if we look at this chest X-ray, we will see that the pulmonary vasculature is quite clear here, while this lung is devoid of pulmonary circulation. This is due to occlusion of the right pulmonary artery on this side, so we couldn't see pulmonary circulation in the right lung. The Hampton hump sign is the presence of an wedge-shaped opacity in the lung. If you see this triangle is due to occlusion of the lower branch of the right pulmonary artery, so we don't have an blood supply to this area of the lung, resulting in opacification of this part of the lung. On doing echocardiography to patients with pulmonary embolism, if you could remember from the pathophysiology, we mentioned that we will have an right ventricular dilatation due to the increased pulmonary vascular resistance. This will result in dilated right ventricle. With the dilated right ventricle, the tricuspid valve annulus also will become dilated, resulting in tricuspid regurgitation. We could see dilated main pulmonary artery. We will have an elevated pulmonary artery pressure and septal flattening. What is a septal flattening? We just mentioned in the pathophysiology that the RV pressure overload results in dilatation of the RV. This will push the interventricular septum toward the left ventricle. This is what we call the septal flattening. Lastly, which is very important, is the McConnell sign. The McConnell sign is very specific for pulmonary embolism, and it is conclusive of pulmonary embolism. This is defined by RV free wall hypokinesia. The RV has two walls, the free wall, which is the lateral part, and the part which is related to the interventricular septum. With the interventricular septum will be pushed toward the right ventricle, while the RV free wall or the lateral wall of the right ventricle will show an decreased motion. This is what we call an RV wall hypokinesia or McConnell sign. The pulmonary CT angiography. The pulmonary CT angiography is a gold standard because it allows direct visualization of the occluded pulmonary artery branch. Do we have contraindications to the pulmonary CT angiography? Yes, we have two important contraindications that you have to keep in mind. The first is a renal impairment because we need to inject dye in the pulmonary CT angiography, which is contraindicated in patients with renal impairment because it might worsen the renal functions, and in patients with contrast allergy. Do we have other methods to diagnose pulmonary embolism in the presence of contraindication to doing pulmonary CT angiography? The answer is yes. The ventilation perfusion scan, or what we call the VQ scan. The VQ scan is a radioisotope scan in which we inject a radioisotope material in the blood. This radioisotope material is absorbed by the lung, so we can visualize the pulmonary circulation or the blood supply to the different parts of the lung. As we said, it is an alternative to pulmonary CT angiography in patients who have contraindication for doing pulmonary CT. as patients with renal impairment, patients with contrast allergy, and in pregnant females in order not to expose them to more radiation. What are the other investigations that we could do to the patients if we are suspecting that the cause of pulmonary embolism is DVT? So we need to do an venous duplex on both lower limbs to diagnose or exclude the presence of DVT. Pulmonary angiography is rarely used nowadays. Why? Because pulmonary angiography is an invasive procedure in which we get an femoral venous puncture, and we pass with the catheters to the pulmonary artery, injecting dye into the pulmonary artery directly to visualize the pulmonary arteries. It is invasive procedure, so it is not preferred for diagnosis, having a non-invasive techniques that are very accurate, like the pulmonary CT angiography, to diagnose the patients, so it is rarely used nowadays. Going to the treatment of pulmonary embolism, when we are dealing with a patient with pulmonary embolism, we have to classify the patients into two categories: the patients with hemodynamic instability and the patients who are hemodynamically stable. What is the meaning of hemodynamic instability? The meaning of hemodynamic instability is that this patient has an decreased cardiac output, his blood pressure is very low, or he is in a shock state. Those are the patients with hemodynamic instability. In the patients with hemodynamic instability, we have to provide them with oxygenation or mechanical ventilation. We have to give them a thrombolytic therapy. I'm sure that thrombolytic therapy was explained to you in the patients with myocardial infarction. The most commonly used thrombolytic therapy are streptokinase and the recombinant tissue plasminogen activator. The value of giving the patient thrombolytic therapy is to dissolve the thrombus rapidly, and after then those patients are provided an anticoagulation. Anticoagulation could be either an unfractionated heparin, low molecular weight heparin, or fondaparinux. Fondaparinux is an active factor X inhibitor. Patients who are hemodynamically stable usually are not in need of thrombolytic therapy. However, they also should receive anticoagulation in the form of unfractionated heparin, low molecular weight heparin, and fondaparinux. The anticoagulation is mainly used for a short time during the hospital stay. After then, the patients are provided what we call long-term treatment. The long-term treatment is also anticoagulation, but in the form of an oral medications. This could be either an vitamin K antagonist or warfarin. And the NOACs. NOACs is the abbreviation of the new oral anticoagulants. Thank you so much. I hope you have enjoyed the lecture. You have understand everything about the pulmonary embolism, and for revising anything about the pulmonary embolism or knowing further informations, you can go back to current medical diagnosis and treatment. And thank you again.